Hello. A very good evening to all the faculty members and the delegates. I am Dr. Dhammajeep Tabhade from Emcure Medical Services, and on behalf of Emcure Pharmaceuticals Limited, I welcome you all on the occasion of No Thrombosis Live in Box. No Thrombosis Live in Box is the scientific initiative dedicated to all interventional cardiologists, wherein we used to learn and understand about various clinical scenarios in terms of the interventional cardiology perspective. And for that, we will be having the faculty, the moderators who will be discussing, and the cases will be presented by the expert interventional cardiologist. Let me take this honor to introduce the course director for this scientific initiative, Dr. M.S. Hiremat sir, who is the director of Cath Lab at Ruby Hall Clinic, Pune, who been the ex-president of CSI 2017, convener of National Interventional Council of India, CSI 2004-6, proctored many intervention cardiologists and has given live courses across the globe, participated in some of the groundbreaking clinical trials. Due to some unavoidable reason, sir is not able to join this meeting, and this will be taken by our course moderator for this meeting. First moderator, Dr. Girish Nosundi sir. It's my privilege and honor to introduce Dr. Girish Nosundi sir. Sir is the senior interventional cardiologist and director of Cath Lab at Apollo Hospital, Bangalore. Sir had extensive experience in the field of cardiology so far, performed over 1700 angiograms through femoral, radial, and ulnar approach. Sir has presented numerous research papers and written for several journals. Warm welcome, sir.
Thank you.
I would like to welcome our next course moderator for this event, Dr. Snehal Kothari, sir. Sir is the interventional and honorary consultant cardiologist at Lilavati Hospital, Mumbai. Sir has over 30 awards and distinctions in his credit, like the gold medal at University of Mumbai, the best original article of the year 2002 by API. Sir has over 8 years of teaching experience in DNB cardiology programs. Over 60 abstracts been presented by him at the national and international meetings. Sir has over 30 publications at reputed journals and co-authored a textbook, Cardiovascular Safety in Drug Development and Therapeutic Use by Springer in year 2017. Warm welcome, sir. I would like to welcome Dr. Gaurav Verma, sir, who is the first speaker for today's event. Dr. Gaurav Verma, sir, is the consultant cardiologist and director at SMBT Heart Institute, Nashik. And he will be presenting his case, a case with 2 chronic total occlusions in AMI setting. Warm welcome, sir. I wish to welcome our next speaker, Dr. Shravan Kumar, sir, who is the consultant interventional cardiologist affiliated with Paras Health Management and Research Institute, Patna. And he will be presenting with us his case, left main dissection, stitch in time, saves 9. Warm welcome, sir. Let me take you through the agenda for this event. We will be having the opening remarks from our moderator, Dr. Girish sir, followed by first case presentation by Dr. Gaurav Verma sir, and the discussion pertaining to this case amongst the moderators. Then we will go for the second case presentation by Dr. Shravan Kumar sir, followed by the discussion amongst the moderators, and we will conclude with the remarks by Dr. Snehal Kothari sir, our moderator. And with that note, I would like to hand it over to Dr. Girish Nausundi sir for his opening remarks. Thank you. Over to Girish sir.
Thank you, Dr. Deep. I mean, as usual, Emcure has been championing this mission of understanding how to deal with thrombosis. Thrombosis is everywhere. It is in the pulmonary vasculature, coronary vasculature, peripheral vasculature, cerebral vasculature. And we've been having multiple talks, not only on the thrombosis, but also cardiovascular disease, especially with respect to interventions. And bright, young and experienced operators are bringing in their experience and enriching all our understanding. Again, for today, we have two more wonderful cardiologists bringing an acute MI CTO and a left main dissection. I'm sure it's going to be a great learning. So thank you again, and let's go to the first case.
Dr. Deep, can we invite Dr. Gaurav?
Yeah. Over to Dr. Gaurav sir. Can share.
Hello, hi, good evening. Can you hear me all?
Yes, sir, you're audible.
Sure.
Yes,
I'll
Dr.
just,
Gaurav.
hi, good evening, all the moderators and the speakers and the fellow, the people who are visited us and are there to listen to us. It's a great privilege and honor to be here in front of the esteemed moderators. I'm going to present my case. Let me share my screen for a while. It will take some time, maybe.
You might have to make him host, Dr. Deep. Is it?
I'll just start. Just a minute. Yeah. So, as the name suggests, I'm presenting a case in which I had to encounter, a case in which we had two CTOs in the patient who presented to me with acute coronary syndrome, acute inferior wall MI. Can you see my screen?
Yes.
Yes, sir. Yes, it's perfectly visible. You can just make it up full screen.
Yes. So the history goes like the patient was a 60-year-old male who was admitted with acute inferior wall MI of 18 hours duration. On admission, his blood pressure was 100 millimeters systolic, pulse rate of 88 per minute. EC showed a typical ST elevation is 2-3 AVF, and echo showed a compromised LV function with EF of 30% and hypokinesia in both inferior and anterior wall. So we thought that being patient out of the actual window period of thrombolysis, and we had the facilities for PAMI, and patient was quite breathless and having ongoing angina, we thought that we'll directly take him for with the intention of PAMI. And we stabilized him for a bit, and then when we took him for PAMI and when we saw the angio, this was the horrific angio what we could see on the angiogram. The shoots, if you can see that the LED is totally occluded and it's a calcific chronic occlusion as we can observe. Thus, only surviving vessel was a small circumflex. When we turned toward the RCA, again it was a chronic, looks like a acute on chronic occlusion, and it appeared that there's some chunk of thrombus as well, which is filling and which has caused this acute MI presentation of the patient. So we analyzed that it's a calcific CTOs and we may require rota. And once we restore RCA flow, patient may get some stabilization. So we thought that we'll try to open the RCA first, and if we can stabilize some flow, and then we can plan the LED in the next sitting. With that intention, we went ahead. We wired the RCA. Then we took some small balloon dilatation of 1.5 to 10 balloon, but there was no significant runoff which we could see distally. So this, alarmed us that we are dealing with a high thrombus burden. There's no flow even after a small balloon dilatation. LED is also CTO, and this can create trouble if we find a no reflow in this sitting. So what we thought that will give intracoronary thrombolysis and will wait for 48 hours. And other thing was I didn't have a rotablation or IVL at that time on my shelf. So and in acute MI we always concerned about no reflow with rota. So we thought of that giving thrombolysis, we may give some benefit to the patient and will come back again. So we gave 5 ml of tenecteplase intracoronary and 10 ml of tirofiban and stopped there and plan to tackle at a later date with the intention that we may have a suboptimal result, may land up in no reflow and which may worsen the patient which is almost hemodynamically in a stable state. After 48 hours, we came back again. Now we had rota as well as IVL on my shelf, and this was the initial angiogram. Wiring was not that difficult. We started with a run through wire, but the balloon crossing was difficult. We thought that I'll be able to cross to a balloon easily because of thrombotic lesion, but it was not that easy. What I thought of. So we gave a serial dilatation with 1.5 and 2 balloon, and you can see there's a waste in 1.5 balloon as well. Then gradually we increase the size and up to 3.25 we dilated the RCA. Then gradually we thought that we'll stent it. We planted a stent in the proximal segment. Then decided to put a distal stent. Had a distal stent inflation also, but there was a waste in the mid segment. There we thought of using an IVL balloon, and we used a 4x12 IVL balloon in the distal segment in stent, which is not a recommended indication for using an IVL, but seeing the scenario in post stented segment with not a great dilatation of the stent, full expansion of the stent, we used it, but we could find a good result, and this was the final result post IVL. So we were satisfied with the flow, and after opening this, we thought that we'll go towards the LAD. We cannulated with a 7 French GBU 3.5 guiding catheter, but you can appreciate there's a calcium in the proximal segment. We are aware of that. We had IVL and rota both ready with us. There was some difficulty. We started with the CrossFit 200. There was some difficulty in crossing the wire. Then we passed a pilot 150 wire, which was also not that easily going that. Then we took another pilot 150, and this time it went. We took a support of 1.5 balloon, gradually dilated it, and sequentially used 2 balloon. Finally, used a bigger stent to first come across till that diagonal. We didn't want to use that, lose that diagonal, which is always a worry in CTOs and low EF patients, because even a small diagonal loss can keep you in, land you in some trouble. So post stenting, we put another stent in the proximal segment. You can appreciate there was significant, waste in the proximal segment of that other stent what we put in the proximal end. So again, we thought of doing an IVL here, and we had to use 2 wires to push that IVL balloon down. We used a 2.75 into 12 IVL balloon there. And finally, we got a very and we were quite happy. And after maybe 48 hours, we discharged the patient. Patient is in follow-up since last 3 months. His EF is improved to 45. So just to give you a message that calcium is a big challenge for all of us to handle, and we sometimes find these acute and chronic occlusions which may keep us in trouble, and I will be of great help, especially when we worry no reflow or there's a huge thrombus burden in this setup, and especially in a post stenting scene. Although it's not a guideline directed indication, but sometimes we have to take the help of these modality also, and this is a good alternative as we can see in this example also that sometimes I will do help in exchange of taking that rotas complication, and especially in PAMI settings when opening a CTOS challenge, we may come out after maybe a 2 days gap, and we may be more successful. Laser is a modality, but because of cost availability we don't know, and I will like our moderator to share their views on the laser, and it's a promising thing which is going to come in your future. Thank you, and we'll like to have a discussion.
Thank you, Dr. Gaurav. I think that was a great demonstration. You were acutely aware of your own limitation of available hardware. That is the key to giving the patient the best chance that they have. There are a couple of things here. One, delayed presentation of acute myocardial infarction. The second one was poor ejection fraction. I think hemodynamics are very important to maintain. You told me there wouldn't need for heart failure therapy at that point. Blood pressure, respiration, heart rate seemed fairly all right. So that should tell you that one of them is a chronic ischemia and the other one is an probably acute ischemia, which is not too terrible. Otherwise, 18 hours of MI, 30% ejection fraction, you will not have a very stable patient. Third, since it's already in post 18 hours, if patient has presented to you, there is some compensation that has happened, which is maintaining the hemodynamics, and it may give you a little more time compared to if somebody had presented within 2 hours of acute myocardial infarction, 30% ejection fraction, and very friable thrombus. Then you have this nightmarish slow flow, no reflow phenomena much larger than somebody who presents later with an organized clot, which may embolize to a branch but not diffuse slow flow or a no reflow. And then once you perform the angiogram, you had probably a chronic occlusion on the LAD, but an acute occlusion because on the RCA clearly visible because a thrombus straining was visible on the right coronary artery. You may have a better experience of intra-arterial thrombolysis. But again, today we all speak about high bleeding risk. We should be very mindful of what we use in terms of cocktail to reduce the bleeding risk. And earlier we can at least establish TIMI 1 or 2 flow. It is better than waiting over next 24 to 48 hours, giving a pharmacotherapy without being certain that flow has re-established. Why? Because we may have re-established the flow, but muscle would have died. The whole idea of doing a PAMI is to get at least TIMI to flow within 90 minutes time. So once you found a large thrombus burden suspicion, if your 1.5 balloon had gone and cleared, 2.5 balloon would have crossed. There's no harm in dilating with 2.5 balloon and re-establish some flow into the distal PDA PLV so that the myocardial viability is preserved and further necrosis of the myocardium is prevented. One tool is you can use a microcatheter, cross the lesion, and inject through the microcatheter a contrast to see what is the distal RCA look like. And it would give you a fair idea of what is the length of occlusion. What is the advantage? If you're even able to get 2.5 millimeter balloon dilated, you can even directly stent, and without post dilating, without causing slow flow, you can call the patient back for a post dilation after 48 hours. Without establishing the flow, if I call them back and 48 hours later re-establish, maybe I give the patient suboptimal outcome than what I would have done had I established the flow in the first attempt that I performed the angiography. I think apart from that, it was very well thought out. You chose not the rota, but you wanted an IVL because the IVL balloon could cross. Today, one of the strategy to treat calcium is if your balloons do not cross, then the rotablation. If the balloon crosses and there is imaging available to you, if there's a circumferential calcium more than 180 degree, thickness of calcium plate is more than 0.5 millimeters, I think you're better off with an IVL than just a rotablation. I think that is a good tool. Another tool that you can have is a Wolverine balloon, which is a bladed balloon. If the calcium is not more than 0.5 to 0.6 millimeter in thickness, the balloon itself will crack without the IVL. In an acute MI, you can always try this balloon because it does not squeeze the all contents. It causes controlled dissection of the internal vessel and gives you a lumen. And going to the LAD, I think you strategized well and executed it very good. And these are my thoughts on the case. I would ask Dr. Kotari for his insights.
Thank you, Dr. Girish. So congratulations, Dr. Gaurav. It was a really challenging case, and I think excellent demonstration of how you handled it. I think Dr. Girish has covered all the points quite extensively, and I don't really have much to add. But I agree with one of the points he made that you have to keep the bleeding risk in mind as well when you're trying to use a cocktail of drugs. So usually I would be reluctant to use both a thrombolytic and a 2B3A inhibitor at the same time. So that is something you may want to consider the next time you are faced with a similar situation. Also, I think agree with your decision not to use rota in an acute thrombus setting. So although the case was titled 2 CTOs, I think I would agree with Dr. Girish. I think the RCA was an acute event. The LAD was the CTO. If the patient has been was stable after the RCA intervention, I would have probably deferred the LAD intervention. I would have when I know that it's a CTO, it's a complex situation. You already had a difficult time handling the culprit vessel. I would have probably thought of staging the LAD intervention, but you did a great job. The result was excellent.
Dr. Snail and respected Dr. Ganesh, can I share 2-3 points? Just to favor why I choose this strategy, in the sense that of late we have found that when there's a huge thrombus burden, there's a high chance of no reflow, and we all know that with no reflow, there the prognosis is not good. Second, when we're doing PAMI, it has been seen that we slightly undersize the stents, because we want to just don't want to overstretch the vessel and don't want that segment also to get involved with the no reflow, because it has been seen that when we stretch over, it can lead to no reflow. Like Dr. Girish said, that of course we can come back later and post dilate it. We can just have a small dilatation and come back again later. Having said that, regarding the thrombolysis, there's a paper by Dr. Jayagopal, and he actually published his data in 2020 in CSI Delhi. After that, we have started using this regime of 5 ml tenectenyl paste with 10 ml GP2 and after that we continued GP2 for 24 hours. And he has a very good experience of 50 plus cases in which in the primary setting, he doesn't thrombolize, he doesn't do a stenting, he just go inside, open the vessel, maybe TB1 or TB2 flow, whatever he gets, and then he thrombolizes and comes after 24 to 48 hours. Usually there's one school of thought is that when you give thrombolysis, you wait for 10 minutes. If you get a good flow, you can stent that moment also. But we have tried in around 10 cases now that in which we, in acute MA setting, especially in younger patients, not this case, when we establish a flow and the thrombus burden, we thrombolize, after 40 hours, we don't even need a stent. So this is our experience and we are definitely going to publish it as well. But probably, we have some change in our thinking and strategy, like we don't try to stent at that moment because we, have, burnt our fingers with no reflow sometimes. So, yeah. And the patient was quite...
I agree with you, but my only point, had you achieved the TIMI 2 flow at least, and then not stented, you had gone back just with thrombolysis and called him back, I completely agree with you. But if I do not have even TIMI1 flow and I wait for next 48 hours and I do an angiogram, again, it is, there's no antegrade flow, then we have lost the opportunity.
Of course.
So that's the only point. Strategy is right, but maybe in this particular case, we should have endeavored to achieve at least TIMI2 flow.
Absolutely.
And then
Yes.
left him. So in this situation, if I can give you this input again, what we do at Apollo, I'm the director here, we use a microcatheter to drill across the lesion and put in or inject the contrast to understand the length of the distal vessel, which is healthy. So now you know from proximal to distal, you know that from the guide, you're filling the proximal vessel, from the microcatheter, you're filling the distal vessel. So you know the occluded segment. You dilate with a balloon of that from healthy to healthy. And if you get a good size of the distal, we even stent it and post dilate. Don't worry about, getting full opposition, but just get at least TIMI2. You can always you can call the patient back onto the table anytime, but please achieve at least TIMI2 or 3 in the first instance. That is the goal of a primary angioplasty, nothing else. Otherwise, great.
So totally agree, sir. Totally agree. Thank you.
Thank you. Thank you, Dr. Garg.
So I think all valid points, because once you cross the 48-hour horizon, the point of restoring flow itself can become a matter of debate. But what was your antiplatelet strategy? What antiplatelet had you given before you took up the patient?
Sir, we trust only ticagrelor. Our experience with ticagrelor is only good. We have quite a event with clopidogrel, and prasugrel we have reserved only for younger patients. This is our protocol at our institute.
Okay. So in the you mentioned about some literature where there has been experience with using this cocktail, and was that also on top
Yes.
of ticagrelor?
No, that was combined. They had this Dr. Jayagopal. He's quite famous in South. His paper is around 50 odd cases, and they started in around 2000. They have around 10 years experience, and they have used both clopidogrel and ticagrelor both.
Okay.
So and they didn't find even a single case of high risk bleeding or some complication because of this regime.
Okay. So that's what I was trying to point out, and because if you already have Tika on board, and then we use this kind of a cocktail,
yes, there's a risk, of course.
This be at the back of my mind, in terms of bleeding risk.
Right.
So should we move on to the next case?
Sure.
Yeah. Can we move on to the next place, please? And thank you, Dr. Gaurav.
So just to update, as we got a message from the next speaker, Dr. Shravan Kumar, that he just got some emergency case. So right now he's in cath lab actually. That's the message from our the manager over there.
No issues, sir. If somebody have a case to present, or I can present one more case. Just
so
to
nice of you.
With the permission from both the moderators, if
Yes,
Dr. Gaurav want to go with the second case.
No, it's really nice of you. Why don't you please show us something more interesting? Thank
sure,
you.
sir. Sure. So I'll present one more case. This is slightly more, challenging for me, and I'll just like to share how I did that. And will require, of course, the expert opinion of all my esteemed and learned moderators. Just a minute. So you can see my screen.
Yes, sir.
Okay.
Yes.
So
Just
this
make it
case I
Okay.
did a year back, and the case was a very diffuse calcific, disease patient with distal left main bifurcation, and she was quite an old lady, and she was a diabetic, hypertensive, and again she presented to me with intraoral MI, which was not thrombolized. She came late after 5 days, and the EF was around 45%. We took her for angiogram, and you can appreciate that there was some disease, the ostium of left main, and this was a non-dominant RCA, which was having a tight lesion. And in the left system, we had a long, diffusely diseased left main with dominant circumflex with distal bifurcation both in OM as well as in the circumflex. More so, the LED was also diseased. You can see appreciate the calcium here. And this was the LED diffusely diseased. So of course the option was bypass, was consult the relative, but the problem with the patient was, just to highlight, this is the calcium segment. You can appreciate how the distal left main has a chunks of calcium there. And the problem was this bifurcation, which is dominant LCX, and we cannot lose any of the branch, neither the circumflex nor the OM. Then we had a tight distal left main stenosis. Ostial stenosis was also there in the left main, and LED is showing diffusely diseased mid and distal segment. So choice was bypass, there is no doubt about that, but patient was a post-COVID patient with an injury in the lung, and her lung function was just 30%. She was CKD with creatinine of 1.9. And after all discussions, we thought that we'll do plastic with whatever rescue we can give to her, whatever help we can offer her. So plan was to tackle first the distal bifurcation, because both the branches were quite of good size, and both were significant in view of the non-dominant RCA. So I planned to tackle both, then distal LM and LED proximal segment. But my hassles were that I didn't have imaging because of the cost issue, no IVL that time. Only ROTA I could convince them, because they were from a poor socioeconomic status, and cutting balloons. So I planned to tackle left main and LD OM. I didn't plan to even tackle LED, because I never wanted to put a very huge LED stand just to get a good result. And it was small caliber artery and diffuse disease, and we know that with mid LED lesions we don't have a good long-term prognosis as well. So as I cannulated my EVU catheter, there was severe damping of the pressures. So I had to just immediately, you can see there's a dye staining inside the left main, and I have to pull my catheter immediately back. And this area was my first front to tackle, and you can see this tight stenosis in the OM in the bifurcation region of the circumflex, and it's a diffuse fibrotic calcific disease. So OM was wired first. It was not that difficult, but you can see that in circumflex there's a almost a 90-degree angle, the bend to that, and this was a nightmare for me to wire that artery, and it was not successful. I tried for quite a while, 5 to 10 minutes. I tried with different wires, but I was not able to go in that circumflex. So with time and the repeated trials, the OM started to occlude. So what I did was I immediately took a small balloon, dilated that OM branch to maintain that flow in that artery, and also dilated that junction to give a space for my wire to move, because wire was not moving. Then at 12 balloon dilatation, I found some space in that bifurcation area, And luckily the circumflex was still flowing, and then I could pass cross it pilot 150 wire inside the circumflex. And after that we did a pre-dilatation of the both the branches sequentially. Then this was the result post a good high pressure dilatation of both the branches. Now we plan to stent. So we opted for a minicut strategy for circumflex OM, OLS, circ being a difficult entry. So we stented that with a 2.532 stent, kept a balloon 2.7512 in OM, crushed the stent, but post stenting, there was some less of the flow. So we had to go again into the stent, again have to dilate that stent. And then we took a balloon, the stent again 2.7536 into the OM up to the circumflex. And post stenting again, you can find there was a less of the flow in the circumflex, because probably it was a acute MI milieu. I told you that the patient was a inferior wall MI case who presented late. So then we did a pod with 3O balloon, then recrossed it, did a good kissing dilatation, and we had a good appreciable result post balloon dilatation. So we are satisfied with this result, and now we shifted our focus towards the distal left main. Cross the wire, and here I didn't, I planned a provisional strategy for the simple reason that in a calcific lesion and circumflex being not that tight, I wanted to keep it in a provisional strategy. And if need arise, I will put a tap. I will do a tap stenting. So I dilated the LED lesion, but before that I also took a 2.75 balloon just to occlude the circumflex lumen so that the plaque shift should be minimum. This is a strategy which we sometimes do to prevent the plaque shift. Then we use a cutting balloon. We used a 3O into 3 into 10 cutting balloon inside the LED. After that we took a stent. And again, we used a gel balloon technique in which we kept that balloon inside the L6 ostium, dilated this 3O into 36 stent till that proximal part of the left main. You can appreciate the calcium also on the lower surface of the left main. Then we did a pot. And then we took a 415 stent, keeping a wire inside the sinus so that we can have a idea where we are putting our stent. You can see the wire inside the sinus so that we should have fair idea. We are keeping our stent just at the ostium. Another thing, cranial view, we confirmed our position before we stented. Then we did a final pot with 4 into 18 balloon till the LED ostium, and also dilated the proximal part of the LED, and this we came out with a final result. I never intended to put a stent inside that diffusely diseased mid and distal part of the LED because of the small caliber and not a good, I wanted to jail that all the LED. And this was the result in the epicaudal view. It was quite satisfactory. But again, having said that, being a calcific disease and no IVL, I want to know the the opinion of my esteemed moderator that what would they have done in this scenario when you have only PTC as your option.
Firstly, thank you, Dr. Gaurav, for willing to share another very interesting case. You're pushed to the wall. You do not have onboard imaging. You do not have onboard IVL or rotablation. That's a great challenge to take on. But as you appropriately said, the best therapy would have been CABG, but for whatever reason, that could not be delivered to the patient. So what is the next best thing? Once you find significant disease in a left dominant system, and the disease is in left main and the circumflex in the LED, it is not just about revascularization, but also about hemodynamic support. Should be very, very mindful of it. And whatever worked, you must work with a hemodynamic support backup. Without an IABP, or an ECMO in a dominant circumflex who already has slightly compromised lungs, we are risking more than whatever probably risk we anticipate 5 to 10%. Second, I think your strategy of stenting from circumflex into the OM across the dominant circumflex, if the part of the circumflex ostium after the OM is not very diseased, it's a great deal. It's a great choice, because although it's a bifurcation, you're treating like a provisional main branch into the side branch, and you got a good result, good TIMI3 flow. But when you came into the left main, I nearly had heart attack that you left a balloon across in the circumflex ostium when you stented the left main to LAD in a calcified lesion. We could be lucky, as you were in this case, but that balloon can get entrapped. This is not done except in LAD diagonal bifurcation, where you want to put a stent in the main vessel with the proximal part of the balloon proximal to the stent. You will rarely position a balloon in the side branch beyond the origin or just at the origin. It needs to come back proximal to the stent in the main branch. There are instances, the balloon may get stuck. Forget the balloon, wires have got stuck. So that's very, very bold. Just because we get lucky and we get away with it, we do not consider that as a proper option. I'm yet to see a literature where the entire balloon is beyond the main body of the stent. I think that is avoidable. If I'm really concerned about that, I would use a much longer balloon in the side branch. That means I will place a 30 millimeter balloon from the left main into the circumflex. But the proximal part of this balloon in the side branch, circumflex, will be proximal to the proximal end of my left main to LAD stent, so that the balloon does not get crushed between the calcium and the stent. And thirdly, you had a very well-appearing angiographic end result without much compromise on the circ ostium, and good left main to LAD runoff, TIMI3 flow. Although we haven't revascularized the distal LAD, there is sufficient flow into the septals and diagonals to keep this left main to LAD both the stents. So strategy is fair in the situation that you are in. Now, you asked us if we were to do it, how differently we would do this case. I think the first, when you have an ostial left main or a long left main, body of left main, I think it's very important to make side holes into your guides, because there is going to be dampening, and inadvertently one of your assistant injects, you may land up dissecting the left main. So always have a couple of side holes in the guiding catheter, and always take 7 or 8 French, not 6 French for sure. And the third, you need to factor in the diameter of LAD and circumflex, and 75% of that addition will be the diameter of the left main. 4.5 would still be undersized for a dominant circumflex in a left main. Probably 5 is the diameter for the lady, if I were to image it and do it. We normally never implant a stent in the left main without imaging, whatever it is, because it's not a crisis. We could have waited for an image, because we are giving her one good chance. We are doing a bifurcation across the left main, bifurcation across the circumflex to OM. And thirdly, I think I appreciate what you have done. We should, such patients, if they can afford or willingly, in about 3 months, please call them back for a repeat angiography and understand the consequence of what has been the result of what we performed. I think this is all I can gather at one go.
Sir, just to highlight few points regarding that gel balloon technique. Dr. Girish, you are there?
I think we lost him, but you can continue.
Yeah. So first, what Dr. Girish has mentioned about the trap balloon technique, that is a older technique than in which we used to keep a balloon outside the margin of the stent, so that if we trap, we could easily dilate the balloon again and come out, right? First. Second, of course, what is said, it has been only tried in non-left main diseases till now. But in our center, we have done a study of around 15 patients. Same thing, that we have, occluded the left main when we are putting a provisional strategy. Dr. Girish, you are there?
Sorry, yeah, I am very much there. Sorry,
Yes,
I had lost.
Just to highlight, sir, whatever you have said about trapped balloon technique, it is a older technique. Now we have a modified balloon technique available, and that has been published in Euro Intervention in 2021, in which they have used a smaller balloon of the size of the this side branch, or 0.5 size of the stent what we want to keep in the main branch, right? One other thing, they have put till the ostium in the modified balloon, MBT what they call it, and they have not found even a single patient in which the balloon was trapped. Second, in our center we have done 15 left main cases with balloon trapping of side branch with provisional strategy, and we have done 150 cases of this gel balloon technique with non-left main cases, in which we now use routinely, because the wire gelling is now obsolete. It doesn't help. What is our experience? And balloon is a wonderful strategy when we have a tightly diseased ostium of the side branch. It is not too big. It's 2.5 millimeter. So our strategy now in our center is gel balloon technique with a smaller balloon of 150 odd cases. We didn't have even a single balloon which has got trapped. And with that confidence, we have started using in left main cases, and we have now 15 cases. And I am going to publish a case report of 10 with a year of follow-up in some of the esteemed journal in some time.
That's something to discuss, because we are yet to see more of this work. If you're done, I'm very proud.
And sir, believe me, if you can try, in some cases in which you fear that there's some thrombus in the distal left main, or there's some plaque 40-50 which you don't want to stent in a non-dominant circumflex, you put a balloon, gel it, nothing happens. Now the newer stents are quite flexible. Balloon comes out very easily with the quality of balloon what we use, and of course we have to use a newer balloon. Ox balloon does not work there. And our strategy is that we occlude first the side branch with 4 or 6 millimeter of pressure. We put a stent at nominal pressure of 8 or 10 atmosphere. We deflate the stent. We pull out the balloon. Then we go at higher pressure of 14 to 16 with the stent. And absolutely there is no much plaque shift. Of course, kindness shift we cannot prevent it, but we have found that the flow is maintained with TIMI3, and we don't need to recross. And this case,
this balloon, does it stay in the side branch completely, or some portion of it is in the main branch?
We keep just a millimeter in the main branch. We just occlude the ostium. This is what modified balloon technique is. In 2021 in European journal, this is documented. The other technique is now obsolete, in which they used to keep a bigger balloon till the shaft of the outside, just out of the stent. And they have found that there were some dissections, some underinflation of the stents. So there are 3 more techniques which has come up, in which they sometimes put instead of a balloon, they gel it with a micro catheters, in which in one they use this modified balloon technique, but they again recross and do a pot repot strategy they have done. But this, of all the available data, we have make our own protocol, in which we just dilate at a nominal pressure. We implant a stent at a nominal pressure of 8 to 10, pull out the balloon, and believe me, balloon have not even got entrapped even once. You try it yourself, and I don't know your experience, but for me, gelling a wire is useless. If you don't gel a wire, I don't find it much relevant just to put a wire in across. So this does help. Only thing is you have to be careful of the size of the balloon what you use, and non-NC usually semi-confined what we use, and in nominal pressure, so that there must not be any dissections.
Dr. Kotari, your comments on that?
Yeah, no, so I have no experience with this at all, and I found it, extremely bold to do this. And of course, considering that you have so much experience, it's a different situation. But you should certainly publish and disseminate this data for others. But I do agree with some of the points which Dr. Girish made, that just because somebody has refused a surgery, if you're taking on this kind of a challenge, then you should make sure that you have all the right resources at your disposal, and plan it in a proper way. Because even if you're trying to do good for the patient and you don't have all the resources at your disposal, you could expose you to considerable risk if something were to go wrong.
Right, sir. Absolutely. Imaging is must now for left mains and IVP, like Dr. Girish said.
Yeah, so it's better to defer the procedure, and if a patient chooses not to undergo the option you have recommended, then they have to be prepared to shell out the cost for all the other things which you need to do for your own protection. Because in the environment in which we function today,
Absolutely.
You might expose yourself to considerable risk.
Absolutely. Totally agree.
I think that's a great new perspective, Dr. Gaurav, that you brought. Let me also go through the data and a couple of things. I have tried doing, keeping a smaller balloon, maybe half the size of the side branch in the LAD diagonal situation, but never in a left main. And more so, if there's a calcified lesion, I would be concerned if the balloon gets trapped between my stent frame and the calcium. And most of the time, my balloon has been partially in the side branch and partially in the body of the main vessel, because it cannot dissect within the stent covered area, probably maybe 1 or 2 millimeters. And as you said, we deploy the main stent at about 6 atmospheres, deflate the balloon, pull back the side branch smaller balloon, and then inflate the main body stent at 10 or 12 atmospheres, and then do a pot. I mean, you don't post-dilate the stent with the same size before the side branch and above the side branch. We change the diameters. Above the side branch, we got a higher diameter, and below the side branch is smaller the diameter. The single most important factor determining the patency of side vessel is the stent size and the diameter of the balloon that you use for post-dilation. Over-dilating the stent is the major cause for neocarinal shift and obstruction of the side branch. So whenever we do a side branch, we always image, even if it is an LAD diagonal or left main circumflex. Never try to dilate a distal vessel more than it is nominal size. The minute you dilate extra, it pinches the side branch. So that's been my understanding. I think imaging will give you a lot more information. You are having many, techniques, but then I think imaging would make it much more precise, is what I would like to tell you, Dr.
Sir, one more point, sir, just to ask your perspective for provisionals. Do you always do a final kissing, or you don't do? Like just put a stent over dilate with a pot and just leave it, or?
I open the side branch if the side branch is more than 2.5 millimeter in diameter.
Always you will do a kiss, right?
I would not do a kiss. What I do is I just put the one more balloon across the stent into the side branch, go a little distal. When you cross for a side branch opening of the struts, it is not a kiss, because the minute you do a kiss, you are causing intimal injury to the side branch vessel. We should not touch the intima. Take the balloon and keep the dot on the distal dot on the balloon at the stent struts and inflate the balloon just to open the stent in the main vessel. So if I'm going from left main to LAD as a main stent, and I've dilated 3.5 into the LAD, osteoproximal LAD, and 4.5 in the left main, then I recross into the circumflex with another wire. And if the side branch circumflex is about 3 millimeter, I take a 3 millimeter balloon, keep the distal dot of the 3 millimeter in the part of the stent which is there in the left main across the origin of circumflex, and the dot does not cross beyond the stent frame. And I open the struts and then come back. That's the way to open the
Sir,
side
but
branch.
moment you don't do a case, definitely the stud at the circ will get towards the LED, and that will narrow the main branch stent, isn't it? That is why kissing is recommended.
No, that is why you need to come back and do the pot. After you open the side branch cells, it is only to prevent neo-intimal proliferation on the stent struts.
Sir, but at the distal edge, when you dilate, of course, the pot is done before the carina, right? But when you dilate a smaller balloon at the distal edge, the stent will hang towards the the main branch, isn't it? Unless you do a case. Yeah, towards the
of course. No, let me just come back to you. I am just opening the struts across the circumflex ostium. After that, I take out the side branch balloon. Then again, I take the main body LED ostium of the LED. I'll dilate with 3.5, and rest of the left main I'll dilate with 4.5 before coming off. What I have done here is just to open the side port for the circumflex without any links or the struts hanging there. That is the purpose, not to get complete opposition of the main stents into the ostia of the circumflex. You cannot achieve that. The purpose is to prevent these stent struts hanging there on which endothelium can grow in the future.
It means after putting a small balloon till the ostium of the circumflex, you again go with a bigger balloon for LED, is it?
Not bigger balloon, the size of the LED. Size of the LED, and again,
it will again compress the stud towards the ostium, isn't it, sir?
Strut of the circumflex. I'm not concerned. I am not trying to oppose the struts to the ostium of the circumflex. You will never be able to achieve, because circumflex ostium is funnel. It's not straight, spherical. All right. It is going to be like a funnel. So the purpose here is not to have too much metal across the origin on which neo-endothelialization can handle. This is not about, because ostium is not diseased. That is the notion why you're not doing a two-stent strategy. You think the circumflex ostium is not so much diseased that it requires another stent. So you're just opening the cells of the left main stent towards the circumflex so that nothing covers it.
But the idea of doing a pot is always like that. You don't go to the carina for whatever open the cells you have opened towards the circumflex, isn't it? But once after opening the cells, if you go again into LED, it will again compress it, isn't it? Like you said,
what does it compress? What does it compress?
Like you have dilated the circumflex ostium, you flare up that origin with the smaller balloon, 3O balloon, like you said, for 3O circumflex artery, and then you go again with 3.5 LED balloon. Again, the stud what you have taken away from the ostium, they will again come towards the ostium, isn't it?
Impossible, yeah. You need to image it. See, then I think you're not imaging. I can tell you that. You start doing OCT more and more when you do bifurcations, you'll understand a lot more.
Then what do you mean kissing, sir? Means what is the harm with the kissing?
No, you're damaging the intima unnecessarily. I will ask you, go into a healthy vessel and inflate the balloon and come back. Why are you damaging? You will cause neoatherosclerosis dissections. You're harming the intima, no? You should never touch. Why we talk so much about balloon hang on the stent edges? Why is the restenosis are common at the balloon edges? Because they cause damage to the intima without being covered by a stent or drug. Any balloon that causes contact and distortion of the media will have implications. So you should never do, unless it's a side branch 2 millimeter in a diagonal, you go and do a kiss. We don't mind. But if it's going to be anything more than 2.5 or ostial circumflex, we are digging our own grave. If they come back with the restenosis, then it's very difficult.
Like you said that you always undersize. Suppose there's artery 3 and you go with a 2.75 and do a kiss with that. Will it still damage intima?
Of course. You know, how certain are you? Have you imaged that the balloon will open only on one, it will spherically open all around and it will cause not damage? You know what is the atmospheric pressure in the car? It is 4 atmosphere in your car tire. And here you're going at a pressure of at least 6-8 atmospheres. Don't think that is very friendly to the vessel. You should not. I will not make even 2 millimeter pressure onto a healthy segment. The worst situation when I have to, anchor balloon technique when I try, I always know that I've caused unrequired injury.
Yes.
Right? So worst place to cause injury is the ostia. So you should never do that. Just go open the strut. Now spherical opening has happened and the struts are prolapsing into the circumflex. Now even if I take a left main big balloon, it is not going to bring back the opened cells. You get my point? They are going to stay opened.
Then why do they for the pods, sir? Then why do they insist that you don't go to the carina, because they will again put the struts towards the circumflex like what we do just before carina, isn't it?
No, you did not get my first point. Carina means you can go up to carina if it's a single stent strategy. Okay, if you're using single stent strategy and your main body balloon goes into the ostium of the left main balloon goes to the ostium of the LAD and you dilate it, you're shifting all that metal into the circumflex. You're making 3.5 into 4.5, at least 4. So do not take your left main balloon into a smaller vessel size. Going up to carina means do not go where the actual size of the vessel is smaller. Now, if you have done a bifurcation, then there are two. If you have used 2-stent strategy and done a bifurcation, never go closer to the carina because there is a metal which is perpendicular to both the vessels. Because of your kissing, you have opened 2 lumen and there is a sharp edge of carina, neocarina, and it is taken its own shape to maintain the eddy flows of the blood.
Of course.
If you take your left main balloon and distort that carina to any one side, you will seriously increase the chance of restenosis because you are moving the stent away from the ostia of both of them. That's why you need to stay away from the carina if there are 2-stent strategy too.
Okay, sir. Thank you so much.
Thank you, Dr. Gaurav. And I think we really made use of the time for this meeting.
Yes, sir.
And then close the.
Yes, sir. So I can just read the message, the concluding remark shared by our moderator, Dr. Snehal sir. That excellent initiative, delighted to be part of this meeting. Great cases by Dr. Gaurav and very insightful comments by Dr. Girish. Need to leave due to another commitment. Thanks. So that concluding remark itself suggests that the meeting was wonderful, cheerful, and I can say in one word, successful. With the interesting cases as presented by Dr. Gaurav Verma sir, and I'm much thankful on behalf of entire Emcure team for that. I'm thankful for both the moderators, Dr. Girish sir and Dr. Snehal sir, for nicely directing with the discussion followed by each case presentation. And with the hope of meeting with the next session in the next month with much interesting cases, and with the thank to all the audience who are watching us this live inbox, no thrombosis even today. Wish you all the good time ahead, and thank you very much once again for participation and the deliberation. Thank you, sir.
Thank you, Dr. Deep, and thank you, Dr. Gaurav. Good night.
Thank you, sir. Good night.
Good night, Dr. Gaurav, sir.